Hello friends, Janice Mitchell with My PFM, and I'm really happy and excited that you're here to join me. We are going to be discussing Levator avulsions today. So let's just jump right into it. This is being recorded so you can access it at any time. You can stop, start, and replay. All right, so let me share my screen here. Can you see that okay? All right, let's get going. So, Levator avulsions. You may have heard this term before, and it may sound kind of scary, but we're going to talk about it. And by educating ourselves, I think that can be very empowering. So, what are Levator avulsions? Where do they occur? How do they happen? Who do they happen to? And how to get your life back after having a Levator avulsion. So number one, where do Levator avulsions occur? Let's just talk about some terminology here. So this is a female side view. If you took a female body and you cut her in half from the front to the back, this is the belly in the front. These are the buttock muscles in the back. That's the pubic bone and the abdominal muscles, and then the tailbone and the spine. The pelvic floor muscles attach here at the pubic bone and then stretch back to the tailbone. You have the bladder and the urethral canal. That's where urine exits. The uterus and the vaginal canal, and then the rectum and the anal canal. This is the clitoris, and then this would be the vulva here. You have several layers of pelvic floor muscles, and multiple muscles make up each layer. Your deepest layer of muscles is called your levator ani group, okay? And that's where the term Levator avulsions came from, because it's affecting that deep layer of pelvic floor muscles. Now let's look at the bottom view. So this would be if you are at somebody's feet and you're looking into their perineum from below. We have the pubic bone up here, the tailbone. You can see the anus here. That's where poop comes out. That's the vaginal opening. That's the urethral opening. And then you have multiple muscles. So you can see multiple muscles. These muscles, it's difficult to see the 3D dimension here, but these muscles are the deeper muscles underneath. Okay, so these are more superficial, these are deep, and then these are more your glutes and so forth. Okay, now what we're going to do is look into the pelvic floor like we're looking into a bowl. So with this view, we're actually looking into the pelvic floor like from the head. Okay, so that's the pubic bone in the front, and that would be the spine coming up. This opening here is called the levator hiatus, and that's the opening for the anus there. So you can see, again, the pelvic floor muscles. Now, it's really important, I think, to understand some of the anatomy here. So you have muscles that are more on the inside here. They attach to the pubic bone, and then they sling back around and attach to the tailbone. And then you have muscles that attach more out to the side and stretch around. And then you have other muscles that aren't necessarily represented in this diagram. And we're going to talk a little bit more about muscle terminology and muscle naming in a little bit, because a lot of there's actually some variations in the literature about what the muscles are called. And so I just want you to be aware of that. Some of the things that we're going to discuss today, I don't necessarily have all the answers. I'm presenting to you the information that I have, but a lot more research is needed on Levator avulsions. And so this is a good starting point to learn. Imagine that your pelvic floor muscles are like a trampoline. So the trampoline is here. These would be your pelvic floor muscles. These bungee cords are like the ligaments, okay? And then this person would be like the organs. So basically, if you could visualize a person jumping on a trampoline with a bungee, that's very similar to the support system that we have in the pelvic floor and the pelvic floor muscles. So you have the trampoline here, and then you have these ligaments that help to support the organs. So if the pelvic floor muscles themselves are very stretched out, or they're weakened, or they're injured or torn, then that's going to affect how well they support those pelvic organs, right? And then because you have these ligaments that are also helping to support the pelvic organs. So if the pelvic floor muscles aren't doing as good of a job at supporting those organs, then the ligaments are going to help to support those organs. But over time, those ligaments can also get stretched out if you don't have that support from below. So that's the basic concept that I want you to think about here. And literally the pelvic floor muscles are kind of like a trampoline. So they give and then they bounce back up. They give and they bounce back up. So think about like if you were running, if you were just doing a little light jog or a little baby jump, you might have less pressure on the pelvic floor muscles versus if you were pounding, the pelvic floor gives, rebounds back up, gives, rebounds back up. So it needs to have that elasticity to be able to do that, but also the coordination and the stiffness to be able to support and to rebound. So there's multiple variables and factors in pelvic floor muscle health that we need to consider. All right, so again, imagining that the pelvic floor muscles are like that trampoline, gives, rebounds back up, gives, rebounds back up. And I've superimposed a trampoline here on top of the pelvic floor because I think that that is a helpful visual. And as we go through, I think you'll see it even more. Let's go back to terminology. So levator avulsions. Levator is the levator ani muscle group that we talked about, those deep pelvic floor muscles. And avulsions means to tear off. Okay, so to tear. You could have a ligament avulsion, an avulsion injury where a ligament tore off a little chunk of bone even sometimes, but avulsion is tearing. Okay, so what are levator avulsions? The pelvic floor muscles are torn from their insertion point on the bone. Okay, so imagine that little spring there was torn off because, well, we're going to talk about that, why it happens. But basically, that is the basic principle behind levator avulsions. The pelvic floor muscles are torn from their insertion point on the bone. There's been a question about, can the pelvic floor muscles, like, do they ever tear mid muscle belly? I don't have any data on that. The only data that I have seen is where the pelvic floor muscles are tearing from the bony insertion point there on one side or the other. And we'll talk more about that. Okay, so this is what a levator avulsion might look like there. So you see where the muscle is actually torn from the bone. Let's go back to the anatomy here just a bit here. So that's the rectum, that's the rectal canal, that's the vaginal canal, and then that's the urethral canal. So again, here the pelvic floor muscles are torn from their insertion point on the bone. Now that inherently widens the levator hiatus, right? So if you go back and look at this image here, you can see that now that hiatus, the levator hiatus, which is the opening where the baby passes through with a vaginal birth, that levator hiatus now is wider. Okay, so that's a very important concept to understand there. There are different terminology, there's different terminology, and we're going to go over some of that in a couple slides. But the basic point here that I want you to consider is how many springs have been lost. So was it 1 spring? Was it 2 springs? Was it 3 springs? Was it 4 springs? And of course, the pelvic floor muscle fibers, we don't consider them to be springs. There's ways that we can measure the tears and how extensive the tears are, but understanding it as this trampoline, I think, is a really good analogy. So how many tears have been, or how many springs have been lost? So you have that basic concept. The more springs that have been lost, the wider that levator hiatus will be, right? So if you have only a spring on one side that's torn, then it's not going to widen the levator hiatus as much. If it's 2 springs, like on each side, or if it's 3 springs or 4 springs, then that opening is getting wider and wider. Now, so the width is important. The depth is also important. So this analogy doesn't really show the depth concept very well. But if you think about that trampoline, instead of it just being one layer, remember we showed how the pelvic floor muscles have multiple layers. But even within one muscle belly, it's not just a thin paper sheet attached at the top. It has depth to it as well. And so it's not just the spring on top, but if you could visualize a trampoline that has several layers of a trampoline. And so if you had, let's say it had 3 layers of springs. So remember, with the width, we're looking at how many springs were lost side to side. With the depth, we're looking at how many springs are lost top to bottom, or midsection to top, or midsection to bottom. If you could visualize like your bicep muscle, so it's a thick muscle, right? If it was torn, you're looking at it, was it just one layer of tear, or was it just a partial tear? Was it a full thickness tear? So how much was it? Small, how deep was the tear? Basically small tear, deeper tear. And so that's also going to affect recovery and function. Is it unilateral or bilateral? So what this means, is it just one side or is it both sides? Because you can have one side or you can have both sides involved. And then which muscles? And so I think this is confusing even for healthcare professionals and providers and researchers, because there's different terminology out there for the muscles. Now, in the physical therapy world, and with most of the literature that I've seen and the courses that I've attended, this muscle here, so this, we call it medial, so the muscle that's closest to the inside of the body, right? So closest to the urethral opening. This muscle is called the puborectalis, and it slings, it attaches there at the pubic bone and then slings around the rectum to attach to the other pubic bone there. But there are variations in the literature about what the most medial muscle is called, and also how it's structured. So I want to bring that up here. So we're calling it the puborectalis, but there's also out there, I'm going to stop sharing my screen just a minute here. This is a book. It's called Evidence-Based Physical Therapy, and it's written by Dr. Carrie Bow, and she is like my pelvic floor hero. And literally, she has a whole chapter here on pelvic floor muscles and their origin and their insertion and their names and so forth. And so let me share this again so I can pull it up so you can see it. In her book, basically, she's recommending that we use the term pubovisceral, and that would include these 3 muscles: puboperineal, pubovaginal, puboanal. And then she also has puborectal. She didn't call it puborectalis. And so just understanding that there's some variations in the terminology. There's also some variations in what you're going to see in terms of the pelvic floor muscles anatomy and how they're represented. So what I'm representing to you here today is pretty mainstream, but there are some other options out there. And I can't say that I am the final authority on this. So I want to just you to understand that concept, that there are theories out there on how differing theories on what we call the muscles and how they're all laid out and so forth. All right, and so then how many muscles are affected? And so that would, depending on how you're naming the muscles and how you're breaking the muscles apart, like in this slide here, you know, the pubovisceral, that has 3 submuscles there, right? 3 components to that muscle. How, you know, how many muscles are affected is going to be affected by how you're naming the muscles, and then also how did you have a unilateral or a bilateral avulsion? How wide was it? How deep was it? You know, looking at all those different springs and what's affected. I can't say that with a really traumatic injury that some of these fibers out here couldn't be torn. So, you know, imaging is going to tell you what's been affected, and, you know, working with that team, I think, is very important. And then we're going to terminology. So there's different, even in the literature I'm going to share with you today, you're going to see all 3 of these classifications of levator avulsions. So some people call them partial versus complete. Some people call them minor versus major. Some people classify them levator ani muscle injury 1 or type 2. So type 1 or type 2. So you have variations out there. So when you're reading the literature, just understanding that there's different ways of classifying avulsions. Now, how do we measure avulsions? So a very common mainstream is to measure it by 3D or 4D ultrasound. That it can also be measured by MRI. So I'm going to introduce this concept to you. Again, I don't feel like I'm the final authority here, but I'm sharing the information that I have. So number 1, they are using something called the plane of minimal dimensions. And this is a primary reference line drawn from like the front of the pelvis to the back of the pelvis. And this reference line is what they use for assessing defects. And so that ultrasound is going to take images, serial slices of images, every 2.5 millimeters from 5 millimeters below that line to 12.5 millimeters above the line. Okay, and there's 2 primary approaches. So using the levator urethral gap or the assessment of visible defects on 3 or more serial slices. And then there's multiple scoring systems. So for people that are using the levator urethral gap, that's basically measuring, remember that levator hiatus and how wide it gets. So that's the levator urethral gap. So measuring how wide. So let's jump into some of the multiple scoring systems here. You can see this is some of the imaging that I took a screenshot here of ultrasound slices. So you need to be a trained, you know, radiologist to be able to interpret this. But once, you know, you have someone that has been trained showing you some of the different defects and stuff, it can be very interesting. All right, so just understanding that's the basic summary. Let's go back here. I want to just go over this. So these slices, so remember the serial slices are being taken from that line, the plane of minimal dimensions, every 2.5 millimeters from 5 millimeters below to 12.5 millimeters above. And so depending on how many of those slices you have a defect will determine how you're categorized, what kind of levator avulsion. Is it complete or partial? Is it major or minor? Is it a type 1 or a type 2? And so you need those ultrasound measurements to be able to classify. And then literally there's different scoring systems out there, but those scoring systems are all based on those slices of ultrasound and counting, you know, how many slices there's a defect. And then if you have X amount of slices as a defect, so let's say one of the scoring systems has 12. 12 total slices. So if you have 9 or more, then that's considered a complete, or if you have 6 or less, that's less. You know, that is just an analogy. That is actually not numbers. So I'm not here to share with you all of the different scoring systems and how radiologists score levator avulsions, but just understand that there are multiple scoring systems out there and that they use those serial slices, and that's how they categorize what type of levator avulsion is there. Okay, so now we're going to talk about how it affects pelvic organ prolapse. And for each of the articles, I have the reference below, and I took a screenshot of the abstract. And so I will share this presentation with you so you can go to PubMed, or you can find some of the research out there on the internet, but it's all referenced here. So the effect on POP, pelvic organ prolapse. The strong association between pelvic organ prolapse and levator avulsion can be explained to a large extent by a larger levator hiatus and weaker pelvic floor muscles after levator avulsion. So let's break that down. Number one, here's that wider levator hiatus, right? The hiatus is wider because this muscle is torn right there. And so why would a wider levator hiatus lend itself more to pelvic organ prolapse? Well, there's less support, right? The bladder is sitting right there on top of that hiatus. And so if there's less support, so that muscle has been torn, think about that analogy of like a hammock or the trampoline. So if you have something sitting on top of that trampoline and those trampoline springs have been torn, that's going to impact how well the trampoline is supporting from below, right? And then the second piece here is weaker pelvic floor muscles. So yes, if you have a muscle tear, the muscle is going to be weaker. It's not going to function as well as it did before. That doesn't mean there isn't hope and help. So we'll talk about that more at the end. Levator avulsion. So levator avulsion, if you have a levator avulsion, you are at a major risk of prolapse. Okay, it's a major risk factor for prolapse. If it's a large avulsion, the pelvic floor muscles are up to 40% weaker, which is really an incredible number. All right, now, so if you've ever studied levator avulsions, research out there, there's a physician by the name of Dr. Hans Peter Dietz that has done an incredible amount of research on levator avulsions. And so here are some of his takeaway points about how avulsions impact pelvic floor function. So weakens the muscle by about 1/3 on average, makes the muscle more stretchy by about 50%, enlarges the opening of the pelvic floor, that levator hiatus, by about 25%, more than doubles the risk of bladder prolapse, or that would also be called a cystocele, triples the risk of prolapse of the uterus, and triples the risk of a prolapse returning after pelvic floor surgery. So let's say that you had surgery for pelvic organ prolapse. If you have a levator avulsion, your risk of having another surgery or having that prolapse returning triples. All right, so now who is most likely to be affected by levator avulsions? It's way more common than previously thought. So even back when I first started my pelvic floor muscle therapy training back in 2000, 2001, we had not even heard of levator avulsions. So this is definitely a term that is, or a concept that has been getting more attention recently. But even then, I think the common thought is, oh, that's just a few people out there. But it's much more common than previously thought. From my pelvic floor hero here, Dr. Carrie Bowe, it is now very clear that a substantial minority of women suffer significant pelvic floor trauma in labor. Obstetrical levator ani muscle avulsion is detected after 10 to 30% of vaginal deliveries and is associated with pelvic organ prolapse later in life. So that's an awful number, right? 10 to 30% of vaginal deliveries. Think about how many people that is. Now, risk factors. So the pelvic floor muscles, let's just talk a little bit about what happens to them. So they're a special group of muscles. They stretch from 1.62 to 3.78 times their resting length. So here is a bottom view of the pelvic floor. That's the vaginal opening. Here's the pubic bone. And so the baby is starting to enter that birth canal. And now the baby is crowning. And look at those pelvic floor muscles and the incredible amount of stretch that happens there. Most of your skeletal muscles, if they were stretched, like think about your bicep muscle, and then you took it and you stretched it almost 4 times its resting length, most skeletal muscles would rupture before they were able to stretch that much. So the pelvic floor muscles are very stretchy and very special, but they're not invincible. So what are some of the risk factors for levator avulsions? Forceps delivery, okay? Prolonged pushing. So that second stage greater than 2 hours. Sphincter injuries, we'll show you a little bit about that in a minute. Older at first vaginal birth, and then a large head. All right. So risk factors with forceps delivery, your risk for levator avulsions, if you have forceps, is 3.8 to 14.7. I'm sorry. So 35 to 71% of people with forceps delivery have levator avulsions. And it increases your risk to 3.8 to 14.7. So that's an incredible amount. Now let's look at the sphincter tears and that risk factor. So here is the bottom view looking into the pelvic floor from below. That's the anus, that's the vaginal opening. This smooth area of skin in between the anus and the vaginal opening is the perineal body. So basically the baby is coming out here, and then we can tear from the vaginal opening to the anus, and there's different degrees of tears. You can also tear up this direction and tear into the vaginal canal. So 53 to 79% of women tear, 4 to 11% have a 3rd or 4th degree tear. So here's a little schematic of the vulva. Here's a grade 0, which is nothing, you didn't tear. A grade 1, that's the vaginal opening, that's the anus, so that's a little tear. A grade 2 is a more extensive tear. And there can be multiple levels of grade 2. So there can be grade 2s that go all the way right up to the anal sphincter muscles. But once you start to tear any of the external anal sphincter muscles, then that's automatically should be categorized as a grade 3, which that grade 3 is going into the external anal sphincter muscles, and then grade 4 is going into the rectum and into the internal anal sphincter muscles. So sometimes, you know, there's some talk out there, some statements out there that there are people that may be classified as a severe grade 2 that really should have been classified as a grade 3. So just kind of keep that in mind, that even if you had a grade 2, you may potentially still have had some sphincter, external anal sphincter injury if it was misclassified. Okay, so now when is it possible that levator avulsions can be predicted during pregnancy? So wouldn't that be amazing? Again, Dr. Carrie Bow, in the future, we may be able to identify those women most at risk of such injury and intervene to prevent such damage in the first place. Here is a good article. Can pelvic floor trauma be predicted antenatally? Factors associated with increased avulsions. So increasing maternal age. there is not an age that I can say, okay, if you're X age, if you're above this age, then you're at risk. In this article, their range of people that they studied was 18 to 45. So as the age got closer to that 45, that was a increasing risk factor, okay? And so why is that? Is it due to biomechanical changes? That's kind of what the authors are theorizing. Is the connective tissue less elastic, so it doesn't stretch as well? Is the connective tissue or structures more susceptible to trauma? So there's some theories out there. Another factor associated with it is decreasing BMI. So basically that's your body mass index. And there's some really cool, free calculators out there online that you can go in and you put in your height and your weight, and it I think you also put in your age. I'm not for sure about that, but it calculates where you are. And so the range that was in the study was 18 to 57. So the closer people were to the 18 age, I mean the 18 BMI, the more of a risk factor. And then decreasing bladder neck descent in pregnancy. So the way they tested this was during pregnancy, they had the people bear down, like do a Valsalva, push out. And they looked to see when they did that Valsalva or bearing down, did that bladder, how did the bladder neck, did the bladder descend? And so again, this is a theory. So decreasing bladder neck descent, meaning that during pregnancy, when they, bear down, when they did the Valsalva, that bladder neck did not come down as much. And so is that indicating less distensible tissue? Could that be due to a high tone or overactive pelvic floor muscles? Again, a lot of this information that I'm going to be presenting to you and sharing with you isn't definitive. So even the authors have different theories about things, but there's still so much more that needs to be studied. Okay, so factors that may be protective against avulsions. All right, so increasing bladder neck descent. So that may reflect that the pelvic floor is more distensible and the tissue is more distensible. And then a family history of cesarean delivery. So either mother or sister. If you had a mother or sister that had a C-section, then you were more likely to have a C-section. And then if you're more likely to have a C-section or a cesarean delivery, then you're less likely to have a levator avulsion. That's basically the theory that less distensible tissue may prevent vaginal delivery in the first place. All right, so the authors finished with this. All associations were weak. This implies that antenatal prediction of levator ani trauma is unlikely to contribute to clinical care, meaning that we can't take this information right now and go out there and shout it from the rooftops and say, hey, everyone that is getting, is closer to 45, everyone that has increasing maternal age, everyone that has decreasing BMI, and everyone that has decreasing bladder neck descent in pregnancy. Hey, you guys are all at an increased risk, and we need to look at something for you. Weak associations mean that basically it's not enough to, I guess, guide clinical care, but I still think that it's important to educate and to make people aware that this research is out there, and that if you are one of those people that may be you're a higher maternal risk, you have a low BMI, I think it's important to think and understand that you may be at future risk for a levator avulsion if you go vaginal delivery. By no means am I saying that, making blanket statements, but I think it's important to understand and increase awareness. All right, and as with everything else, more research is needed. Now, how can you get your life back after a levator avulsion? So we've talked a lot about, the mechanics of the avulsions and all of that. Let's talk about the living Okay, so we're going to go over several categories here: more babies, natural recovery, pelvic organ prolapse surgery, levator ani muscle surgery, pelvic floor muscle training, and then pelvic physical therapy. These last two, I'm just touching on them. Really, I think we actually need a whole webinar on each one of these alone for levator ani avulsions. So it just, there wasn't enough time to do all of these justice, but I'll give you a summary. Okay, so one of the most common questions that I get, especially on social media, is, hey, if I have, you know, a levator avulsion or have pelvic organ prolapse, should I have more babies? Can I have more babies? Is it going to make it worse? In this article, it is the first birth that does the damage, a cross-sectional study 20 years after delivery. So let's see what this article showed. Most levator ani muscle avulsions and external anal sphincter defects seem to be caused by the first vaginal birth. Subsequent vaginal deliveries after the first were unlikely to cause further levator ani muscle trauma. Okay, so that looks like good news, right? Of course, there's no guarantees, but that was encouraging. Now we're going to talk about this one. So this basically was called the natural history of levator ani muscle avulsions 4 years following childbirth. The first vaginal delivery is at greater risk for levator ani muscle avulsion to occur, with impact on pelvic floor dysfunction even 4 years later. And this says 4 years, but we know it can impact much later as well. A second vaginal delivery could result in deterioration of levator ani muscle avulsions, but no new avulsions were found. So that other research, you know, this isn't really contradicting that, because that the other research said the avulsion itself, so it was unlikely to have to cause further levator avulsion trauma. This one said no new avulsions were found. So I think the takeaway here is talk to your birth provider and really understand your anatomy and what's going on, or if you're a provider, understanding what's going on with your patients. And I would honestly look at some of those risk factors, like, okay, and also what was their stage? So was it partial or complete? How many slices? What is their function like now? And then looking at some of those risk factors: increasing maternal age, decreasing BMI, and so forth, and make the best decision that you can, because there just isn't a blanket recommendation that you can apply to everyone. Okay, now we're going to talk about natural recovery. So the natural history of levator avulsions 1 year following childbirth. So in this natural recovery, 138 women participated in this study, and it's referenced below. Levator ani assessed at 3 months and 12 months postpartum. They used the ultrasound 6-point scoring system using that plane of minimal dimensions that we talked about earlier. And they were looking at partial versus complete avulsions. And the author's conclusions here is that 62% of levator avulsions were no longer evident at 1 year postpartum. So that's really good news, right? Yay! Partial avulsion has a tendency to improve over time, and it's less common for complete avulsions. Characteristics of women with persistent avulsions versus women who no longer had evidence of an avulsion. So they had a significantly longer second stage of labor, like we talked about, significantly higher rate of forceps, significantly more oasis injuries or sphincter injuries, and they had a greater bother of symptoms. So the lump inside or outside the vagina and the sensation of too loose of a vagina. I do want to mention, because I'm not sure that I have the literature or a slide here, that vacuum assisted delivery does also potentially increase your risk of pelvic organ prolapse and levator avulsions, just not as much as forceps do. Okay, so now another study: change in prevalence of major levator ani muscle defects from 6 weeks to 1 year postpartum, and maternal and obstetric risk factors. All right, let's jump into it. So 300 women participated in all or part of the study. The levator ani muscles were assessed at 6 weeks and 12 months postpartum. They used the transperineal ultrasound. The main outcome measurement was a change in the prevalence of major levator ani muscle defects, and maternal and obstetric risk factors were assessed. So the author's conclusions: 50% reduction of sonographically diagnosed major levator ani muscle defects from 6 weeks to 1 year postpartum. And so this author, is saying assessment of the major levator ani muscle avulsions at 6 weeks postpartum may be too early, because if 50% are being reduced just naturally, by 1 year postpartum, is it too early to, be providing interventions? We're going to talk about that concept here in a few slides, but I think, again, there's not a conclusive answer. Characteristics of women with persistent major levator ani muscle defects and avulsions, so longer second stage of labor, higher neonatal birth weight, and vacuum assisted delivery. All right, now the next article: type of levator ani muscle avulsion as a predictor for the disappearance of the avulsion. 192 patients. They were measured with ultrasound at 6 months and 1 year. And this study classified them as a type 1 or type 2. And so basically all type 1 levator ani muscle avulsions had disappeared 1 year after delivery. None of the type 2 levator avulsions had disappeared. So this author's conclusion: the type of levator ani muscle avulsion observed at 6 months after childbirth predicts levator ani muscle avulsion persistence at 1 year. So going back, just, understanding that regardless of what you call it, whether you call it partial or complete, whether you call it major or minor, whether you call it type 1 or type 2, there are avulsions that are minor and there are avulsions that are major and more severe, right? The avulsions that are minor generally look like they're going to heal better and have more of a chance of recovery naturally than the ones that have that are major and that have more tissue involved. That doesn't mean that all hope is lost. Again, I think this was exciting here that where did we say? So this 50% reduction of sonographically diagnosed major defects from 6 weeks to 1 year postpartum. So they were reduced. So again, there's differing literature out there. There's differing research, and we need more. And there aren't conclusive answers that you can apply to everyone. All right, now let's jump into surgery. So surgery for pelvic organ prolapse. I think that, I'm just going to give you this preface as we enter this, that I am not anti-surgery for pelvic organ prolapse. I'm anti-surgery for pelvic organ prolapse as the first option in most cases. So too many times I'm seeing people that are just being steered directly to surgery without giving some of the conservative interventions a real opportunity to be successful. And so, of course, conservative interventions don't have a 100% cure rate or a 100% guarantee of making you asymptomatic. But looking at some of this research that I'm going to share with you later and some of the protocols, like my baseline recommendation for most people would be to go through like that 6 month of intensive rehab. And if at the end of those 6 months, you haven't achieved your goals and you've given it your 100%, then I think going into surgery is, if you're still having bother and, the outcomes aren't where you want them, talking about surgery with your surgeon and talking about options is a very valid thing to do. I just think too many people are steered there first without giving other things a shot. And more research is needed, but even if you choose to have surgery down the line after your 6 months of rehab, having a better support system with your pelvic floor muscles, understanding better how to manage pressure and how to exercise and how to do things, how to have healthy bowels and healthy bladder, and some of the conservative, even supplemental support options that are out there. I think all of those are really important pieces in even having successful surgical outcomes long term. So it's not a waste of time. Even if you did pelvic physical therapy and you didn't get the outcomes that you wanted, I think that you still learned some valuable information, and hopefully you did 6 months where your pelvic floor muscles have bulked up and hypertrophied and are doing better to help prepare for that surgery. All right, so now let's jump into surgery. 10 to 20% of people with pelvic organ prolapse will have surgery. There's multiple options out there, and I'm not a surgeon, so I don't even have all the information to go over all the different types of techniques. There's non-mesh and there's mesh. Pelvic organ prolapse surgeries. I think it's important to understand that it's compensating for levator ani muscle avulsion versus repairing the avulsion. And we're going to talk about repair surgery in a little bit, but the pelvic organ prolapse surgery is helping to lift that organ and helping to provide more structural support there. It's not repairing the levator ani muscle, right? Prolapse procedures are known to have a high reoperation rate. And remember back to some of the risk factors, if you have a levator avulsion, your risk factor increases to having the prolapse reoccur after surgery. So risk factors for prolapse reoccurrence after surgery: levator avulsions, prolapse stage, and family history. All right, so the practical value of levator ani muscle injury repair. Let's look at this. Because basically we understand that the muscle has been torn. What do we do about that muscle that has been torn? Do we just let it be there, or are we going to try to repair it? There's not a whole lot out there. I just have to be upfront about this. There's not a whole lot out there about repair. So this is an article that I think was the most helpful that I found. And the women's bladder doctor, she's on Instagram, she actually shared this with me. So it's a very helpful piece of literature. The practical value of levator ani muscle injury repair. So it is well known from the orthopedics literature that it's best to repair a muscle separated from the bony emphasis, which is that pubic bone, as soon as possible to prevent the muscle from undergoing significant atrophy. Okay, so that's what the authors said there. Many factors to consider. So signs and symptoms go unrecognized. Why is that? So, let's back up just a little bit. So let's say, you just had a baby and you're having a lot of pain and discomfort and swelling. That may mask the levator ani muscle avulsion. Like, how do you know? And how does your birth provider know? And how does the team working with you know if it's from an avulsion or if it's, just part of the vaginal birthing process? So that's basically what this is saying. Delivery-related pain and discomfort may mask the avulsion. It may be seen as part of the vaginal birthing process. Many staff are not trained to identify. And like we talked about earlier, like you need an ultrasound to be able to identify if you had a levator ani muscle avulsion. So are you going to, how are you going to screen people? And also going back to that prior article that, I think it was 50% had reduced by 1 year, or 62% in that one article. Like if that's the case, so almost 1 out of 2 people are going to recover naturally without, even trying anything like this. So again, these are questions that I don't have the answers to. And I'm bringing them up. So identification of levator ani muscle avulsions immediately postpartum is difficult. Swelling pain requires imaging. Many defects resolve spontaneously. So 0 out of 12. So 0 at month 0 postpartum. So basically you just had the baby. 40% of patients had a levator hematoma, which is that swelling and that kind of like a large blood mass. At 6 months postpartum, 13% of those defects persisted. So repair of the levator ani muscle research is very limited. And from everything that I can see out there, there really isn't one type of surgery that is the gold standard. There's research going on about this, but there's no standard procedure that says, okay, this is what you should do to repair the levator ani muscle group, and this is when it should happen. So here's a statement from the authors. Given the wealth of accumulating evidence, the question is not whether we should scan the pelvic floor before attempting repair. Rather, what is the best way to scan the levator ani muscles? Because there is also some research out there saying, you know, is it even important to scan the muscles before surgery? And so, especially if you're considering a levator ani muscle repair, you'd like to get a scan of it to understand, you know, what's involved before the surgery. So imaging, they are using MRI or the 3D endovaginal ultrasonography. So that's basically going inside the vagina. Muscle status prior to surgery is important. So what is the outcome of the imaging? What is the integrity of the levator ani muscle? Is the muscle innervated? Is there atrophy of the muscle? So how long has it been since there was injury to the muscle? Does the muscle still have nerve supply? You know, I think a really good analogy would be like if you had a bicep muscle avulsion. So that's kind of like that Popeye look, that where the bicep tendon ruptures here and then you have a big bulk of the muscle there. Over time, that Popeye is going to atrophy because it's not attached. So factors to consider. All right, and then also impact on pelvic floor disorders. So we understand that there's a huge effect on pelvic organ prolapse if you have a levator ani avulsion, but there really isn't a whole lot of literature out there on the effect on other pelvic floor dysfunctions like urinary leakage and bowel leakage or pelvic pain. So this part is important as we go into this next. I didn't like what this author said here, or rather, I feel like they didn't fully represent the people with pelvic organ prolapse. So this is one of their, concluding statements. If the levator ani defects are asymptomatic after vaginal delivery and their long-term association with pelvic floor disorders are questionable, what are the clear indications for repairing these defects? So what I'm reading here from this sentence is we're not including pelvic organ prolapse as a pelvic floor disorder, because here clearly in this article they understand that there's a huge effect on pelvic organ prolapse, but here they're saying that's a questionable impact. Well, what I would have liked for them to say is their long-term association with pelvic organ prolapse is established, but their impact on other pelvic floor disorders is questionable. I would have liked that included, and then I would actually take out this final sentence, because if you understand that there's a huge impact on pelvic organ prolapse and that pelvic organ prolapse has a huge impact on quality of life in so many areas, why do we even need this last part? What are the clear indications for repairing these defects? Well, the clear indications are that they're at a risk for pelvic organ prolapse. So, and all of the things that entails. So that's my personal interpretation here. And if you're watching this, I'd love for you to leave me a comment or email me and tell me what you think about that. And again, this is referenced here. So I've given you the author and the abstract, and so if you want to go read the whole article, it's out there. All right, so this is their final statement in their article. Although it is intuitive that a disrupted muscle should be reattached for proper pelvic floor function, any technique developed to repair the levator ani muscle injury should be standardized and follow long-term with both ultrasound and validated patient-reported outcomes to assess objective and subjective changes. So I totally agree with that. At this point, I mean, this is really the only article that I could find, and I found it only because my Euro GYN friend shared it with me. And I had been searching PubMed and searching the internet for evidence-based, literature on levator ani muscle repair. So I agree with this. Any technique should be standardized. It should be followed long-term. As you're following it long-term, you should have objective measures like that you're taking with the ultrasound, and you should have subjective measures that you're looking at the quality of life of these people that had the interventions. So that's the literature that I have on the surgery. Various techniques have been tried. There's no mainstream procedures that work well. Evaluation of whether you're going to do the repair or not must include muscle status. So if you have a muscle that doesn't have nerve supply, what point is there really in reattaching that muscle? If it's not going to work anyways, why should you attach it? Also in terms of atrophy. So if that muscle has atrophied, and it's not in good condition, is a repair even indicated at that point? Or as we continue to evolve and grow and research, might there be some types of interventions that can help the integrity of the muscle and help make some kind of repair? I don't know. I wish we were much further along than we are here, but I'm excited to see what the next 5 or 10 years shows. And then also, who is going to do the surgery? So is it orthopedics or urogynecology? So orthopedics are the ones, like if you have that bicep avulsion, they're going to be the ones that are going in there, and they're the ones that are doing this regularly. And the pelvic floor muscles are musculoskeletal structures, and we're attaching it to bone. So would orthopedics be the most appropriate discipline, or might that be urogynecology, because that's where they are? That's the space that they're living in and that they're most familiar with and that they're the experts in. So it's a question. Long-term levator ani muscle repair research is limited. Long-term studies are needed. We need to know what are the best procedures, the status of the repair, impact on quality of life, and then also just another reminder here that pelvic organ prolapse surgery isn't a levator ani muscle repair. So the prolapse surgery is compensating for that muscle injury. It's not repairing the muscle. Let's go into pelvic floor muscle training. So the injured person is entitled to know at the outset, in general terms, what her injuries are, what the immediate treatment will be, and what may be the expected result. And that's also assuming that we know. All right. So if we know X, Y, or Z, I believe as a healthcare provider, it's our obligation to educate and inform our patients. And just here, like this is back from 1961, and this wasn't specifically on levator avulsions, but it certainly applies to this population. Some of the effects of supervised pelvic floor muscle training. So improved skill. A lot of people aren't doing it well, aren't contracting the right muscles, they're cheating, they may even be straining and bearing down. Improved contractile force. It can hypertrophy the muscles. So if you train your bicep, right? If you're exercising over and over, you're going to get a stronger, firmer bicep that is more bulkier. morphological changes. So it increases the muscle volume, just like we were saying. So we want those pelvic floor muscles to have good tone, good volume. Close the levator hiatus. Remember that hiatus? Helping to close it because you're bulking up that tissue. Shortening the muscle length. So this would be thinking about that trampoline, and if that trampoline was very stretched out and kind of sagging, pelvic floor muscle training is helping to lift that trampoline and shorten the length of the muscle. And then also elevating the resting position of the bladder and the rectum. Morphological changes after pelvic floor muscle training measured by 3D ultrasound. Let me grab some water here. Okay, so this is an amazing article, and if you have prolapse, I strongly encourage you to read this article. You don't have to read every word, but understanding that it's powerful research and really exciting. So in this article, I'm going to share with you what they did, okay? So the program details, because we want what they achieved, right? We want increased muscle volume. We want to help close that levator hiatus. We want to shorten the muscle length and elevate the bladder and the rectum. So they had a pelvic physical therapist that instructed the person and also observed the person contracting their pelvic floor, avoiding straining. They also helped them to understand that we want to contract the pelvic floor muscles before and during intra-abdominal pressure. So intra-abdominal pressure is basically, let's say you cough or sneeze. Anytime that pressure in your core is increasing, then that's increased intra-abdominal pressure. So it might be lifting, it might be jogging, it might be going up and down stairs. Basically, any movement is increasing that intra-abdominal pressure. And whether your body has the ability to counteract that pressure is going to determine a lot of your symptoms. So, leaking and pressure and bulging and pain. All right. So for the first 3 months, they did supervised pelvic floor muscle training with a pelvic physical therapist once a week. And then the last 3 months, they did supervised pelvic PT every 2 weeks. The people had a daily home program. They recorded adherence in their diary, and adequate adherence was determined completing at least 80% of the sessions. And that would be 144 or more home sessions or 14 or more PT sessions. And here's what they did. So they did 3 sets of 8 to 12 maximum voluntary contractions. And I think this is also where sometimes people really maybe fail with pelvic floor muscle training. Like if you go to the gym and you're training your bicep, are you going to train with only a little 1 pound weight the whole time? No, we want to gradually increase, and we want to strengthen. We want a good, strong contraction. So as strong of a contraction as you can do successfully is basically a maximum voluntary contraction. So they did 3 sets of 8 to 12 maximum voluntary contractions. They did 3 positions. So they did supine, which is lying on your back, sitting and standing. They used a type of biofeedback. It was a vaginal squeeze pressure transducer. And we're not going to talk a whole lot about that today, but I think biofeedback can be a really, really helpful tool to help you with a home program of pelvic floor muscle training. It can help you to be able to kind of connect with your pelvic floor muscles are doing and help you to stay consistent and compliant. Now, in this article, they didn't define the rest period and they didn't define the hold period. Now, taking from, again, this book, Evidence-Based Physical Therapy for the Pelvic Floor, here, and going back to this article, Dr. Bowe works very closely with the people that led out in the study, and she was one of the authors. And so she's developed basically this protocol. And so they used it in this study. They've used it in multiple other studies. And in her book, she kind of outlines it here. So the American College of Sports Medicine. No, I actually think Anyways, these strength training principles, it's from a strength train. Oh, actually have it. No, I don't even have it right here, you guys. Let's see. I want to get this because I want to make it. I want to. It is American College of Sports Medicine. Okay, well, I was right the first time. Go with your gut. So these are strength training principles based on the ACSM. It's important that we train the right muscles, okay? So specificity. If you have again, we're just gonna go back to the bicep injury. If you have a bicep injury and you're not specifically working on training the bicep to help increase strength, increase tone, increase flexibility, increase endurance, whatever factors you're working on, you're not gonna have as good of outcomes. And the same thing applies to the pelvic floor. We need to specifically connect with the pelvic floor and train the pelvic floor. Does that mean we don't do other activities and integrate that into functional activities? Absolutely not. That's imperative. That's a very important part of rehab. But we've got to back up and connect first. All right, they also have this principle of overload. So basically, like thinking about using the weights. So we're really trying to strengthen and challenge that muscle. So my kind of concept here is making it as challenging as you can, but still successfully do it without cheating and having good form and all of that. Holding the contraction, holding that maximum voluntary contraction 3 to 10 seconds, and then doing it daily. And then going back here, remembering it's 3 sets of 8 to 12. So you're holding 3 sets of 8 to 12, 3 to 10 seconds. And then adding higher velocity contractions, advanced to eccentric contractions, vaginal weights, advanced positions, wide legs, squats, and then difficult to maintain progress without altering program variables. Again, I think we could do a whole webinar just on this slide alone and some of these principles. Okay, so going on, postpartum pelvic floor muscle training and pelvic organ prolapse. So this is again, Dr. Bowe. What does immediate postpartum pelvic floor muscle training, what effect does that have on a levator avulsion? And that's a question that we don't know. And this article basically raises more questions than answers, in my opinion. Here, I totally agree. So pelvic floor muscle training may help hypertrophy remaining fibers, partially compensating for the trauma. So that's the whole concept behind pelvic floor muscle training, especially for levator ani avulsions. But we need more research about what to do and when to do it. And here's why. So this article, it was a small study, but the walk-away concept here is that it may be beneficial to allow the muscles some healing time immediately postpartum. So it's a small study, but in this study, they showed that the levator avulsion subgroup, the POP-Q stage was actually higher in the pelvic floor muscle training group versus the control group. So they were measured at 6 weeks and at 6 months. And they started the pelvic floor muscle training at 6 to 8 weeks postpartum, and they did it for 4 months. And so, there's just so many questions here. One of the theories, because I attended a class recently, so one of the theories here is that when, during that immediate postpartum period, you have different types of collagen that are increasing. And so is it important to kind of let that collagen lay down those collagen fibers and to kind of help reset the body? Because pregnancy is kind of like a balloon, right? You're growing, 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 and then you have the baby, and that balloon is kind of like pop, popping the balloon. And so everything just kind of, so it's going to take time for those tissues to kind of recover and repair. And so is it possible that instead of doing high-powered Kegels and pelvic floor muscle training in those first few months postpartum, is it possible that instead of doing as much as we possibly can, maybe we need to be considering allowing the muscles more healing time in that period? But again, this is a question. This is not by any means a directive, or I don't even think that you potentially can take this and say definitively, what direction you go with pelvic floor muscle training postpartum. It's a question at this point, but as with everything, we need more research. So going back to pelvic floor muscle training, the benefits of pelvic floor muscle training for pelvic organ prolapse are well established. The dosage, timing, and long-term effect of pelvic floor muscle training on levator avulsions needs to be further researched. We need more research to guide our clinical practice. There is now another emerging theory called the pelvic floor reserve, okay? And so basically going back to that pelvic floor muscle volume. So if I had a biceps injury, and if I went into that injury with a really strong, healthy, toned, good volume, good bulky bicep muscle, and I had some of my fibers torn in that muscle, my function is probably going to be less impacted than if I have a puny, weak, low volume, low tone muscle that had the same amount of muscle fibers affected as the good volume, but the impact on function is going to be a lot higher potentially on the person that had the puny muscle going into the injury. And so this is an exciting theory. I'll read through my bullet points here, but that's basically the concept is, preventing some of the impact potentially on function by improving pelvic floor muscle tone, bulk, endurance, elasticity and flexibility and function prior to going into, a potential scenario where you're going to have injury. Because, the bottom line is with a vaginal delivery, there are injuries that can happen. And some of these injuries do leave people with lifelong impairments. And so, I am one of them. So you may not know a whole lot of my story, but I have pelvic organ prolapse, and I have chosen not to have surgery, and I'm dealing with it very well. Now my son will be 20. No, he just turned 21. Oh my goodness. He'll be 22 in December. So, by using a lot of these conservative interventions that I've learned some of them at courses over the years, but a lot of them have also been kind of self-taught, like, hey, this works for me. Hopefully we'll get some research on this at some point, but let's try this, and it's an option for other people. So I'll go over some of those in a minute, but basically I think this concept of pelvic floor reserve. So had I gone into my first pregnancy or even my second or third pregnancies with really good, strong, toned, bulky, good volume pelvic floor muscles, that doesn't mean inelasticity. We're talking about muscle health, a healthy muscle. Could that potentially have reduced, some of the impacts on function that I've had over the years? We need more research. All right, so pelvic floor reserve, the baseline muscle tone and bulk prior to dysfunction. Some may have naturally bulky muscles, some may have naturally delicate muscles. This may explain why some have issues and others don't. The person with bulky muscles may lose 50% and end up with the same amount as the person with delicate muscles. The person with delicate muscles may lose 50% and then be symptomatic. So like what we were talking about with the bicep. Research is needed. Is it possible to prevent or reduce impairment if the muscles are bulky prior? All right, now the basic concepts here of pelvic physical therapy, and this is I've kind of taken everything that I've learned and categorized it into these two categories. And I think it just makes a whole lot of sense. So if the forces from above, so if you have your pelvic floor muscles here, let me stop sharing just a minute. So if your forces from above are greater than your forces from below, then those organs are going to start falling. And that's the basic concept behind my pelvic organ prolapse course. And so we go into that in depth in the course. But you have different factors from above. So you have intra-abdominal pressure, you have gravity, you have the pelvic organs that are sitting on the pelvic floor, you have the contents within the organs. So if you have a full bladder or a full rectum or a full uterus that has a baby in it, there's more pressure that that pelvic floor is having to hold up. And so that doesn't mean that we that we don't get pregnant or that we don't, eat or drink, right? Because of course we're going to do all of those things, hopefully. But understanding, hey, I have symptoms. Maybe it's due to having a full rectum, and then you go poop and then you have less symptoms. Or, hey, I have more symptoms when I jog versus if I'm sitting on a bike, I feel better and I have less symptoms. Okay, well, let's break that down. Is it due to that increase in that intra-abdominal pressure from the jogging? Is it due to the improved support from below when you're sitting on the bike? Or is it due to a variety of factors? Is it due to your pelvic floor muscle tone and strength? So now let's just finish it out here. Okay. And then improving support from below. So external support, internal support, pelvic floor muscle training, which we just went over some, and then hip and core strength, I think are really important. And we're starting to see more research on this. So I think that that's exciting because we know that the pelvic floor muscles don't work in isolation. They work with the rest of our body, our hips and our core. And so we need everything to work well together. I'll dive into external support and internal support here. Just let me stop sharing. So external support is basically supplementing support from below. So that might be wearing a pair of Spanx, or wearing it's called a femjock, kind of prolapse panties, or using some of these other shorts that have built-in perineal support. And so you're lifting that perineum from below. You're giving a lift to help counteract those forces from above. So that's the concept of external support. Internal support is basically inserting something inside the vaginal canal. And both of these concepts I go into in length in my course. So make sure that you check out those sections because I go over, multiple products that can be used and the pros and cons and so forth. But internal support, so that's pessaries, if you've ever heard of a pessary or a pessary-like device. And, again, more research is needed, and I don't have any research that I was able to find that says, okay, if you use this type of pessary, then it improves support for levator avulsion. That's not out there from anything that I know or that I've seen. However, I do know that there are physical therapists out there. And I have a friend actually in Australia, and she's like, Janice, it's amazing, to see the difference on the muscle function between when without a pessary and with a pessary. And so she said that sometimes when she's, fitting people for pessaries, and she puts so prior to the pessary being in, she tests the pelvic floor muscles and not getting a whole lot of good strength or function. And then putting that pessary in, it kind of helps to support and lift those organs kind of out of the way. And then those pelvic floor muscles are functioning much better. So there is some research out there on pessaries and the benefits of pessaries. More research is needed. There is some research on pessary-like devices like a tampon. So inserting a tampon, but that research is more on, I think there's only a couple articles articles out there, but that's on helping to reduce urinary leakage. But if you think about that bladder kind of collapsing down and that urethral canal where the urine exits kind of collapsing down into the vaginal canal, by putting something in that canal, potentially you're helping to raise that structure up so it can function better and do what it needs to do. That's the goal. So that's external support, internal support. We went over pelvic floor muscle training and then hip and core strength. So I believe we are at the end of our webinar here. So I really want to thank you for making it all the way through. Thank you for your interest in learning about this topic, whether it be for yourself, whether it be for a friend, whether it be for your clients or patients. I think it's really, really important to understand at least the basics of levator avulsions. And so I hope that this, this presentation gave you the basic understanding, and then, provided the literature that we have at this point. So much more research is needed. But again, if you look at where we are now versus even 10 years ago, so much has been done in the last 10 years to help really support the role of pelvic health and the pelvic floor muscles in pelvic health and how they can impact so many areas of our very intimate lives. So I want to encourage you to share this information, be an advocate for yourself, be an advocate for others. Again, thank you so much for being here. I look forward to connecting with you in other ways. And if there's anything that you feel like would be helpful to include in this presentation that I didn't, or if you think that I could have presented something a different way, or if you have an idea for a graphic or animation or something, I'm a very visual learner, and I love to be able to show diagrams and show people, really help. I think it helps to understand anatomy and helps to understand how our bodies work a lot better. So I very much want your ideas and feedback. I thank you again for being here, and have a great one. Bye-bye.